These guys often have ideomotor and limb kinetic apraxia, which is uncommon in PSP, Parkinson's and DLB overall, but not good to separate them. The myoclonus is a good feature to separate them, except it's only present in about 50% of patients. The eye movement abnormalities, well, eye movements can be abnormal in CBD or CBS, but usually there's some subtle differences which we try and pick up clinically. So to try and illustrate the difficulties a little bit of diagnosing this condition, this is a paper that we've just submitted of 1,440 brains that came to the Queen Square Brain Bank over this 20-year period. 21 cases were diagnosed using the old terminology, cortico-basal degeneration, based on the clinical syndrome that the doctors saw. Of those 21 cases, 16 didn't actually have CBD, so that's terrible diagnostic accuracy. It's a useless diagnostic paradigm clinically. I'll tell you what they had in a minute. The five cases were confirmed with pathological PSP. Now looking the other way, of all of the pathological diagnoses in the brain bank, there were 19 cases of CBD, but only 5 of them were diagnosed during life and 14 were only diagnosed post-mortem. And again, so we use this sort of retrospective review to try and improve our diagnostic accuracy. Of the patients that pathologically had that tau pathology of CBD, what did we call them during life? Well, 8 of them actually were called PSP. Only 5, I've told you, were called CBD. Others were called Parkinson's disease, frontotemporal dementia, Tourette syndrome, and some other diagnoses. So you can see during the course of the disease, the clinical diagnosis changes. Initial diagnosis in these guys with pathologically proven CBD, actually they were first told they had Parkinson's disease. So this is not to be smart, because I'm not sure that I could have got those patients the pathological diagnosis right either, but it shows how the evolution of symptoms over time helps us to understand the condition and more accurately diagnose, hopefully. So just finally, if it's not Parkinson's disease, what is it? Well, the prognosis is worse, the burden of care is worse, the medications are less likely to be helpful, and injuries are more likely to occur. This is some retrospective study we published a couple of years ago looking at the time from symptom onset to falls, and patients with Parkinson's disease tend not to fall in the first 10 years. In PSP, they tend to fall in the first 2 years, MSA the first 3 or 4 years, vascular Parkinsonism in the first 6 or 7 years, and dementia with Lewy bodies in the first 4 or 5 years. So you can imagine just from simply looking at falls and the sort of ramifications of that, the burden of care is much more severe in the non-Parkinson's conditions. What can we do about it? Well, PSP information kit is vitally important for every patient, family and nursing home to have, looking after patients with PSP. It's our role, that's all of us, to provide education, optimise the home environment and the community environment they live in, maximise function. That may be through inpatient or outpatient rehabilitation services, that may be through medication trials, that may be through equipment optimisation at home. It's important to enlist the help of carers, because they are the carers and they have a big impact on the quality of life and disease duration. There is an example of a guy that was a big benefactor for the Brain Bank in Queen Square. Very, very rich man from a very, very rich family. They own wagon wheels, the little chocolate biscuits and Selfridges and lots of it. Anyway, developed the first signs of Parkinsonism in the 1950s and died 30 years later. And under the microscope, all we saw was PSP tau pathology. Now these guys pumped in heaps of money. They had a full-time physiotherapist that lived with him and a couple of full-time carers. And even a couple of years before he eventually died, he was still being walked, in inverted commas, with 2 physiotherapists dragging him out in the vast gardens in Canada where the family lived, to do his walks. Now, he had an unusual form of PSP, but it really demonstrates to me that if you're maximising the support for the carers and the physical therapies, you're really going to get the best out of the patient and improve the quality of life. And I think it's up to all of us especially if you're a physio doing research in PSP, to encourage research into the patients and so we can improve our understanding.